Great, thank you. We should almost not have this lecture. It's not about antibiotics, it's about debridement. But I'll cover both, debridement and antibiotics together. John Charney said that nothing destroys the reputation of a surgeon like infection. If so, then my reputation must be pretty rock bottom, because that's all I deal with at the moment. Even before Charney, Berkeley Moynihan in 1926 stated, every operation in surgery is an experiment in bacteriology. And certainly if we're going to put foreign material into the human body, we have to understand the biome, which was so wonderfully explained to us earlier. But in terms of microbiology, antibiotics, I want to talk about how we debride, so then antibiotics have a chance to work. My colleague Vanya Gant from London is a microbiologist, and he has this great saying, antibiotics will make a third-rate surgeon into a second-rate one, but will never make you a first-rate surgeon. And I don't care what your reputation is. I don't care if you're the best knee surgeon in the world. If you do not debride adequately, the bugs will get you. Another of my good colleagues, Professor Bertazzoni from Verona, has this great saying, antibiotics without debridement is like deodorant without showering. You've got to get the sequence right. And I would say to you, based on the last couple of lectures we've heard, that debridement should be so good that the 1v2 stage debate is irrelevant. You should debride so well that should you choose to do a one stage, you can with equal outcome. Which is why I'll spend just one slide talking about debridement. And in Cardiff we have a debridement protocol. It's called a cyclical debridement, and it starts with a surgical exposure, explantation and excision. That moves on to the mechanical debridement of curettage, reaming and lavage, which is then repeated 2 or 3 times until you're certain it's as clean as you can get it. Interestingly, lavage, if I use 4 litres, that's a big debridement. Right? I've never in my life used 12 litres. It's about where you put the fluid, not how much of it you put in. After mechanical, I believe in a chemical, and we've talked about hydrogen peroxide, beridine. I choose acetic acid. Other poisons are available. But you do the surgical, mechanical and chemical before you consider reconstruction, where that's a 1 or a 2 stage, isn't the argument. So here's a case of an infected non-union, and you have to debride, taking out all the bone graft, all the dead tissue, and you need to create a sterile space. Think of your debridement as a bridge between the microbiology, the infected tissues, and the antibiotics. If you don't do the debridement, the antibiotics will not work. So I have 6 principles of antibiotics. Diagnosis, and I won't labour the point because it's been done so well earlier, but you need to know your local flora. The organisms I deal with in Cardiff and in the UK will be very different to the ones here in Thailand, to the ones in Philadelphia and Germany and elsewhere in the world. So you need to understand your local flora. There are some good bugs and there are bad bugs. And my good bugs may be your bad bugs, and vice versa. Dosage. Do not pretend to know enough about antibiotics. Speak to your microbiologist. I classically underdose, and it's been a real revelation to me speaking to microbiologists, telling me where I should have been, and improving my practice. Duration. Do we go long course? Do we go short course? IV versus oral? That's a whole lecture by itself. Duality. I have a minimum of dual therapy. Increasingly, though, I'm into triple or quadruple therapy for the more complex infections. I'm not at home to monotherapy. It's not good enough. Then delivery, systemic versus local, which we'll cover in part in this lecture. And the last D, discuss. We see here 9 wonderful experts in the field, but the 3 in the middle. Vanya Gant, Lorenzo Drago, and Harriet from my department are the microbiologists that help influence my practice and help me, I hope, get a better outcome for my patients. So why local antibiotics? So with systemic antibiotics, you can have a low local concentration where you need it at the infected field, and you also have side effects from systemic disease. Systemic antibiotics. Here's an example of doxycycline. Patients in Wales don't get much sun, so I feel pretty safe in giving it. But universally, when they have their 2 weeks in Spain for holiday, they come back with massive skin reactions to using doxycycline. If you use local antibiotics, you can use very, very high concentrations where you need it. You will get negligible systemic effects. Historically, we've always worried about resistance, but that just hasn't been proven in the literature. we are not seeing resistance. Or if you are seeing it, you didn't debride thoroughly enough. Don't blame the antibiotics. Here's an example. This is his 6th revision. I didn't do the first 5, I admit, but I did do the 6th one. It's a big reconstruction in a complex case, and he's got a multi-drug resistant, vancomycin-resistant enterococcus. That's a bad bug. It's bad because we have so limited choices. So we start off giving linezolid. And linezolid, universally allowed 28 days. We went for about 6 months. And what happened? The linezolid switched off the mitochondria, leading to a life-threatening lactic acidosis. So I've tried to kill him by surgery, and now I'm killing him with the antibiotics. Luckily, when you stop linezolid, this side effect goes away. But his infection came back. So on discussion with the microbiologists, we started daptomycin. Very limited choice. Daptomycin produced a life-threatening eosinophilic pneumonia. So I've tried to kill him by surgery, I've tried to kill him with linezolid, and now I'm killing with daptomycin. This patient now has a persistent draining sinus, but with a stable implant, and I have no intention of doing any further surgery or giving him any more antibiotics. Sometimes you've got to accept you can't do better than you've done. So about delivery, we can use cement, you've heard a little bit about that, direct injectables, sponges or fleeces, bone graft and calcium mixes. And let's go through each one very quickly. Antibiotic-loaded cement, we've got great experience, and it was Buchholz and Engelbert in 69-70 from Hamburg who really pioneered the use of this, despite, it has to be said, John Charney's resistance to it. They were right. I use antibiotic-loaded cement in my 2 stages, and increasingly, although I prefer a 1 stage, I'm doing 2 stages because I have a large debridement field where I have to put internal support bars, a core of fast-setting cement, and then a skin of antibiotic-loaded cement. And we produce this thing called an apple core. This is what it looks like. I've got rods holding 18 centimetres of space apart after my debridement. I've added quick-acting cement to hold the bone apart. I coat that quick-acting cement with antibiotic-loaded cement because it's only the skin where you get the antibiotics eluted from. And this is a pre-mix of Vanc and Gent. And then I stipple the skin to give an increased surface area. And that's my static spacer. You can, of course, use articulating spacers. I would tend to be in the off-the-shelf femoral component and all polytibia if I was doing that. And you can use standard cement and add your own antibiotics. But we can do better than that. There's working on in my university in Cardiff looking at liposomal drug delivery. And essentially using liposomes to deliver the antibiotics, we can double the concentration that we elute from the antibiotic over a prolonged 30-day period consistently. So hopefully we're not just going to have pre-mixed antibiotics, we'll have clever antibiotics that elutes greater for longer. Direct injectables. This is Charles Lautenbach, very much a father figure in my career, and he sadly passed away a few months back. I spent time with him learning how to put in suction irrigation systems. And for the first 2 years of my practice, I was absolutely attentive to this, but I gave it up because it's bloody hard work. You've got to be there all the hours that God sends. It is cheap. It is hard work, and I've got to say, you have to be a real enthusiast to use this system. But it will give you what you want. High-dose antibiotics where you need it. Cords and sponges. Before coatings became an issue, where companies were really investing in iodine coatings, silver coatings, I was using these collagen sponges for my distal femurs, proximal tibias, so I could have a biological local antibiotic delivery system. I did a few of them. I can't promise it was great. The problem with sponges, you only get the one antibiotic, so you've got a very narrow field. Bone graft. I'm the wrong person to tell you about this. Heinz Winkler from Vienna has really pioneered this. It is commercially available. It will do exactly what you want in terms of antibiotic delivery. It's a question of whether you're comfortable putting dead bone graft into any vascular field. And there's always a compromise to be made there. My current practice is to use calcium mixes. It allows me to do an on-table mix of the antibiotics I need to put in there, using bespoke antibacterials, combination therapy, very high concentrations. There's nothing structural about this. It's purely a bioabsorbable delivery system. Complications, You can get about a 15% asymptomatic hypercalcemia. I've never seen it. You will get some seromas and some leakage. And again, the problem there is about soft tissue quality. If you can close well, you won't have any problems. It does play around with the pH, and that may be synergistic with gentamicin and may increase your eradication rate. So I'll leave you a couple of cases. Typical of my practice. Here's a 68-year-old man. He's had two-stage revisions for infection. Both have failed. He's had a free latissimus dorsi flap and skin grafting. He has a hinged component, which is still infected, and no extensors. At aspiration, we grew a staph, we grew a pseudomonas, and a fungal infection. So for me, this is a two-stage. What do? Big debridement, apicose spacer. The stimulant is used for fungal delivery in this case. So we've done chemical debridement, antibiotics, dual therapy, Van Gent, stimulant for the antifungals, both intra-articular, intraosseous, and in a capsule. Leaving about 10 weeks until the stimulants are all absorbed, and then we go back in the second stage, another debridement, silver-coated implant, more high-dose antibiotics than the stimulant. And he's now out at 18 months, no sinuses, not great function, but the infection at the moment is in abeyance. I'll give you one last case. Female, 66, had an aseptic revision 2 months earlier to presenting in my clinic. At 2 months, this is the presentation I get. I've lost the skin, I've lost the extensors, we've got a polymicrobial infection. So again, for me, it's a two-stage. I'm debriding, I'm putting in a stable apicose spacer full of antibiotics, I'm using stimulant for antibiotic delivery, and I'm using a gastroc flap. And here, because this lady has a lot of comorbidities, I'm hoping this will be the only operation I do, and I'm putting an apicose spacer to stay. We've no extensors, so I'm not going to go back and do anything other than arthrodesis, so maybe a one stage is enough. Gastroc flap, I did delayed skin grafting, and here we are 6 months later with fully healed soft tissues. Not a great outcome. The leg is short and it is stiff, but at the moment it's not infected. Faris Haddad has this great saying, even your winners are losers in infection. And he's right. You know, we can salvage things, but they're not as good as a good primary. Quick mention on vinegar and honey. Much as we're understanding the biome and how clever these bugs are, the bugs are also understanding antibiotics. And we are in the foothills of the post-antibiotic era. So we need to think a bit more laterally. I use acetic acid regularly. I have some experience with honey. And recently my colleagues in Edinburgh have just published on biofilm eradication using acetic acid. So we need to think about other ways of doing it other than antibiotics. I'll finish with my principles. Get the diagnosis. Use appropriate dosages. Appropriate duration. Always think duality, never monotherapy. And think carefully about your delivery system. Yes, we need to do systemic antibiotics, but don't miss the opportunity to do high-dose local antibiotics as well. And please discuss. I've had infections, and if you're honest, every single one of you in the room, including our panel, have all had infections. Welcome to orthopedics. Thank you.